Hi everyone, this is Neel Raithatha, consultant audiologist and director of ClearWax. Thank you for joining me in my latest video using the WAXscope. And here we have a patient who attended with bilateral fully occluding earwax. And this is just the patient's left ear you're seeing on screen at the moment. The consistency of the earwax differed from their right and left ear. So whereas in their left ear it was quite mushy and soft in consistency, hence why I've immediately instill some medical grade olive oil spray in their ear to try and coagulate and bind and bond this soft mushy wax together. Their right ear, although soft, is a bit firmer, and I was able to remove that and extract it using the right angled ear hook. Now, as you can see, they've got quite a narrow entrance to their ear. It's not possible really to stretch this ear out too much more. Although a bit later in the procedure, I did use the size 1 specular. So the specular size that I'm using currently is our size 2. And that's got a diameter, tip diameter of 4.25 millimeters. So that's our standard size specular. But a bit later, I did use the size 1 and I was able to dilate the ear open slightly more. So what I'm trying to do is just separate this from the canal walls. There's a few hairs matted in there as well, which can make it a bit more difficult to obtain a suction grip. So I'm just lifting it from the floor of the ear canal here. So this patient last attended about 2.5 years ago. Now, if you are someone who suffers from earwax, a question that I quite often get asked in clinic is when patients attend is, when should they attend next? Now, it's a very difficult question to answer if I've only seen you once or twice. So we need to get into that pattern of seeing how frequently and how quickly your ears secrete earwax. But on average, if you are someone who suffers from earwax, I would say between 12 and 18 months. There's a lot of variation and range there. However, I've got some patients that need to attend every 3 or 4 months, whereas some other patients every 6 to 7 years. So I've just asked this patient, it's been 2 years, I think I said, so just attend in about 18 months, because they admittedly left it a bit longer than they would have hoped, because it did really cause them significant symptoms, including not only reduced hearing but a bit of tinnitus as well. So they already suffer from tinnitus. So tinnitus is if you like, a phantom noise that originates either within inside your ears or head. So it's not an external stimulus or sound that you're perceiving or hearing. So they've been suffering from that. Well, I wouldn't say suffering from it. It's not troublesome for them. It's something that they manage and can quite often phase out if they preoccupy their mind. And that's not always the case for a lot of people who experience tinnitus. But they found that with their ears being blocked, their tinnitus was exacerbated. And thankfully, after the removal, the tinnitus went back to its normal intensity. So I've got this outer layer of soft wax, and you can just see how mushy this more deeper wax is. There is a bit of wax on the eardrum as well, which we remove. In terms of the modified Bristol/Rye Ceremon chart that I kind of devised about a year ago, whereby we classify the consistency of wax in 7 different grades or types. I would classify this as a type 6. So type 1 is when the earwax is extremely dry and hardened, and type 7 is when the wax is literally fluid-like, so almost like a molten consistency. So it's not quite a molten consistency, but so as a result, I would classify this as a type 6. In terms of how blocked their ear is, I think with earwax, it's a area of audiology, ENT, that probably hasn't got its fair share of attention. So with other pathologies, you get kind of grading systems. But to my knowledge, there's no grading system in terms of how occluded an ear is with earwax. So again, when I was developing my ClearWax theoretical training course last year, I also devised a grading system, which I use in my clinical notes. So if a patient reattends, I can review their previous notes, and it gives me an indication of how blocked the ears typically are with earwax. And So I would classify this as a grade 4, which is a complete occlusion. So a grade 1 wax impaction I've classified as an ear that's got up to 25% amount of earwax, so quarterly blocked if you like. A grade 2 will be kind of 26 to 50%, so almost semi-occluding. Grade 3 would be 51% to 75%, so when the ear is 3/4, if you like, occluded. And grade 4 is anything beyond that, so from 75 to 100% blocked. So this definitely fits into the grade 4 category, as does their right ear, which we'll see a bit later. Now, because of the consistency of this wax, it is really, really tricky to suction. It's also not very suitable consistency in some ways to correct. So correct is like an ear scoop. More so because of I would say, the location of the wax is quite deep. It's so that where we're working on now is the inner third of the ear canal, so it's a very sensitive region of the ear. And also there's no real opening for me to insert the correct beyond and over the wax to extract. And sometimes with this consistency of wax, when you do use a correct, instead of the wax coming away, you're almost spreading it across the canal wall, which can then make it even more difficult to remove because we're then having to work very closely to the ear canal. So we can see a bit of the eardrum just at the floor of the ear canal. There's a bit of an opening there. So on screen right now, probably about 7 o'clock. But this residual wax, some of it is impacted against the anterior canal wall and eardrum, so the front parts. In the case of the left ear, the left-hand side of the ear canal. And there is also quite a large plug posteriorly, and in a moment I will revert to the smaller size 1 specular. So I'm just looking a bit higher up in the ear canal, so more superiorly. I've just got this wax in focus. The key about removing this with microsuction is that you don't want to embed the tip of the suction tip too much into the wax because it's quite a mushy consistency. If you apply too much pressure, it will block the tubes. At the same time, you don't want to just hover over it. So you're just kissing the surface and then you just allow the suction to do its work. So you don't want to come away too quickly. You want to generate some suction power. So as you can see there, I'm kind of just lingering the tip of the suction probe onto the wax. There's a few hairs just in this region. So this wax is stuck to the eardrum. You can just see the eardrum in the distance there. You can see the umbo, the centre part of the eardrum. At this stage, the patient could immediately hear significantly better because there is now a passage for sound to travel through the ear canal and vibrate against the eardrum, but want to try and get as much out as possible. So I'm just going to the front part of the eardrum here and the ear canal. I think I'm using the fine end suction probe now. I think I've reverted to the 17 gauge. Initially, at the start of the procedure, I was using the 14 gauge, which is the standard size suction tip that we use in the UK for microsuction. The inner diameter of our 14 gauge is 1.7 millimeters and the outer diameter is 2 millimeters. It's got a very thin wall, which means that when it's inserted in the ear, you're still getting a good view. It's not blocking up too much of the optics, but you're not sacrificing on suction power, so you still got a good internal diameter. So here I'm just now using our size 1 specular. You can see more of the speculum in view, and I've managed to remove this from the back part of the ear canal. Now this plug, I've taken a still image of this, and considering I've already removed quite a lot of wax, it was quite astonishing how big this plug was. And I put it side by side alongside the plug I removed from their right ear with the hook, which came out in one single piece, and they were almost an equivalent size. So I'm just trying to tease this out the entrance. And then I think there's just a bit of wax in the anterior recess, so we're going to try and remove this. It's a bit tricky because they have got a narrow ear, so I'm just getting that in focus. I think actually this is more on the canal wall as opposed to on the eardrum, but as we start peeling this away and removing it, so now the remaining bit you can see is actually trapped in the anterior recess, and the underside of the wax is up against the eardrum. So I get most of this away. Just going to be very, very careful because we don't want to make contact with the eardrum or indeed the front part of the ear canal, because that's very sensitive. So I'm just using the specular to dilate open the ear a bit more, and I'm rotating it so the WAXscope is angled more into the recess. There's very little space to play with in there. So I think I get a little bit more out. So again, I just want to hover over this. I'm happy with that. And I think I'm just going to mop up near the entrance some of this softer wax. So just having a look at the eardrum there. All looks fine. So we're just going to mop this up so you can just see this view here where the speculum is actually not inside the ear, it's external, and you can see the first bend to the right where the hairs are protruding, and where I'm working on now, that's the second bend. So they've got quite a narrow isthmus. The region between the first and second bend is typically quite narrow. A narrowing, the medical term of a narrowing is an isthmus. So again, I'm just using the speculum to stretch open that narrowing. And I'm just going to have one final look at the eardrum. So there's a bit of residual sticky soft wax on the drum because a lot of this wax was impacted against the eardrum, and we did use some drops. So moving on to their right ear, and I've just gone back to the larger specular size, this size 2. This ear was a bit wider, and you'll be able to notice that once I remove the wax, you'll get a much better view. And it was their left ear that they had the most symptoms from. And I suspect with the left ear, it's just more prone to getting blocked because of how narrow the ear canal is. The wax is trying to naturally migrate, but it just gets trapped. So I've mobilised this plug already. I did use some olive oil spray right at the beginning because the left ear required it, so I decided to put some straight away. So it's helped to mobilise it, but this plug is lodged deep in the ear, so I just felt it's not going to come away with microsuction, or not easily at least. So I just reverted to the ear hook. I've just used the side of the hook initially to drag it forwards, and now I've penetrated into the plug, and I'm slowly coming away. If I come away too quickly, the hook could just dissect that. So that's come out in one single piece. We're just going to stretch open the ear, and you can see you can see much more of the eardrum and ear canal here. So that's the tympanic membrane, the eardrum. You can actually see the long process of the incus. So the plug at the bottom, that's the right ear, and the one at the top, the slightly smaller one, is that plug I removed from the back part of the left ear canal. Well, I hope you enjoyed that video, guys. Do take care, keep well, and speak soon. Bye.